Hello and welcome to Triage, rapid legal lessons for busy healthcare professionals, a podcast created and produced by K&L Gates. Each episode is designed to highlight important developments in health law and analyze the impact on our clients and friends of the firm. We hope you enjoy this podcast.
Over the past 8 weeks, Congress and the Secretary of the U.S. Department of Health and Human Services have taken unprecedented steps to expand the eligibility for telehealth services under the Medicare program to help combat the coronavirus pandemic. This Triage episode will explain those efforts as well as their impact throughout the epidemic and considerations for the use of telehealth after the COVID-19 quarantine period and national emergency pass and Americans return to more typical routines. I'm Lindsey Rogers-Seitz, and I'm here with my colleagues, Gina Bertolini and Leah Richardson, and we are attorneys in K&L Gates National Healthcare Practice Group. Our healthcare practice group tracks the evolution of healthcare regulations, including matters relating to digital health and the delivery of telehealth services. Gina, Congress passed the CARES Act in March, and CMS issued 2 interim final rules, one in April and one just last week on May 8th. All contain important telehealth provisions. But before the CARES Act and the interim final rules, both Congress and the U.S. Department of Health and Human Services took important steps to expand the ability of Medicare beneficiaries to receive telehealth services. Can you talk about what those steps were?
Sure. And just by way of background so that our listeners can keep track, because so much has happened in such a relatively short time. On March 6th, as the coronavirus pandemic was just beginning to unfold, Congress passed the Coronavirus Preparedness and Response Supplemental Appropriations Act, also referred to here as the Appropriations Act. The Appropriations Act increased the accessibility of eligible telehealth services to Medicare beneficiaries in the wake of the COVID-19 pandemic. And around that same time frame, the Department of Health and Human Services issued several waivers, some of which expand the circumstances under which Medicare will pay for telehealth services. And then on March 17th of 2020, CMS released guidance through a telemedicine healthcare provider fact sheet and a Medicare telehealth frequently asked questions or FAQ document, which further provided guidance to healthcare providers and beneficiaries related to the delivery of telehealth services. Both the Appropriations Act and the waivers increased accessibility of eligible telehealth services to Medicare beneficiaries due to the COVID-19 pandemic. And they did that in 3 primary ways. They expanded telehealth visits, virtual check-ins, and e-visits. And we'll talk specifically during this podcast about how telehealth services have been expanded. But I want to mention that some of our colleagues at K&L Gates issued a client alert in March, which outlined in detail the Appropriations Act and the waiver provisions, including definitions, site references, and details, not only about the expansion of telehealth services, but also of virtual check-ins and e-visits. And that client alert is available via the K&L Gates website.
Leah, what congressional or agency actions occurred after the Appropriations Act and initial waivers?
On March 27, Congress passed the Coronavirus Aid, Relief, and Economic Security, or CARES Act, which President Trump signed into law the same day. The CARES Act included an extensive $2 trillion federal aid package, including funding for public health programs, tax benefits for businesses and individuals, appropriations for government programs to support COVID-19 relief efforts, and other initiatives to help stabilize the economy. The CARES Act included a provision that provided HHS Secretary expansive authority to waive Medicare telehealth provisions. Then on March 30th, CMS issued a pre-publication version of an interim final rule that provided additional flexibilities during the public health emergency, including changing multiple Medicare telehealth payment rules. And then on April 28th, CMS issued a pre-publication version of a second interim final rule, providing even more flexibility related to responding to the COVID crisis. And this second interim final rule contained telehealth provisions as well.
Gina, let's start with a brief explanation of what telehealth is, and then help us understand what was covered before the COVID-19 pandemic and how these legislative and regulatory initiatives have changed what is covered during the pandemic.
Sure. So there's no single definition of telehealth, but generally when we talk about telehealth, we're talking about two-way telecommunications that allow real-time communication between a healthcare provider and his or her patient. Typically, communications are simultaneous audio and video. Now, there are some exceptions to that and some exceptions that we'll talk about during this podcast. And telehealth, as I've already mentioned, it can include virtual check-ins and e-visits, as well as remote assessments of images. Like any healthcare service, telehealth services are governed by both state and federal laws. And in this discussion, we will primarily be referencing federal laws and regulations regarding the provision of telemedicine, but it's important to note that many states have also expanded availability of telemedicine services under state licensure laws during the COVID-19 public health emergency. And in fact, our practice group has reviewed many state telehealth laws and have had conversations with medical boards about what may be happening next. And we can provide up-to-date guidance on what's permissible state by state for the provision of telehealth services. So that's something we can help with if folks need that. In terms of how the federal law governs telehealth and how that's changed, we'll start with just some baseline information. So current Medicare regulations dictate, first, the telehealth services that can be provided, second, the settings in which telehealth services can be provided, and third, the healthcare providers that can provide those telehealth services. The Appropriations Act, the 1135 waivers, the CARES Act, and the interim final rules that we'll discuss today expanded certain of those areas, allowing payment for services in certain settings during this COVID-19 pandemic that previously would not have been eligible for reimbursement by federal healthcare programs.
The setting where telehealth services can be provided seems like an important component of telehealth services, especially during the pandemic where millions of Americans are under stay-at-home orders. How has this changed?
That's exactly right. It's an important component, and given our stay-at-home orders, that's changed. So I'll talk about that for a minute. Prior to the COVID-19 epidemic and the loosening of telehealth restrictions, telehealth services that would be covered by Medicare generally were provided only when the patient is at what is called an originating site, interfacing with a healthcare provider at what is referred to as the remote site. And generally speaking, Medicare guidelines said that the originating site could not be a patient's home. There were very limited exceptions. One example of an exception to that rule would be patients with end-stage renal disease receiving in-home dialysis. But by and large, the originating site could not be a patient's home. Instead, the originating site had to be a specific eligible site, such as a healthcare provider's office, a hospital, a skilled nursing facility, or a dialysis facility. And then the originating site was further limited in that the patient had to be in either a county outside of an MSA, a metropolitan statistical area, or in a rural health professional shortage area in a rural census tract. So prior to the COVID public health emergency, Medicare prescribed really narrow circumstances in which it would pay for telehealth services, limited to beneficiaries who live in a rural area and travel to a local healthcare facility to connect with a healthcare provider in a remote location. To me, the narrow circumstances in which Medicare would pay for telehealth services, especially given existing technological solutions for both synchronous and asynchronous communication and just the expansion of those solutions really on a very regular basis, that to me illustrated the limited way in which CMS was thinking about telehealth, at least prior to the COVID-19 crisis. What the government has come to realize, and I think frankly what patients and healthcare providers have also seen, is the wide range ability of telehealth to fill the gap when the general consensus is that people need to stay at home unless they're having a true medical emergency. So if you consider now the context of our current public health emergency due to the coronavirus. As we all know, to help prevent the spread of virus, most states and local municipalities have issued stay-at-home orders, keeping people at home and away from brick and mortar establishments, including physicians and other healthcare providers' offices, generally is thought to help reduce the spread of the disease and also to maximize those existing healthcare resources for patients who absolutely need them. So fortunately, Congress and HHS have recognized that telehealth technology and the use of telehealth services has a role to play within this unique set of circumstances. And that is that telehealth can address the immediate healthcare access needs regardless of where people are. So for services provided as of March 6th and for the duration of the emergency, Medicare will pay for telehealth services furnished to beneficiaries in any setting. This includes telehealth services provided to a patient while the patient is at home. And because CMS really wants to encourage its beneficiaries to practice social distancing, change is further expanded without regard to the beneficiary's diagnosis. So now beneficiaries who we generally understand to age are at greater risk for COVID-19 are able to visit their physicians and certain other healthcare providers from their homes, minimizing risk to themselves and others and assuring that healthcare facilities can be available to help the most urgent cases in person. Some healthcare providers and other advocates for telehealth services, such as industry groups like the American Telehealth Association, they've argued for some time that geography should not define our healthcare destiny and that telehealth is a key way to solve access to care issues. I think nowhere is that more evident than in the face of a pandemic with the population on lockdown. And what we're hearing from a lot of our clients is, the circumstances that we're in, as unfortunate as they are, have really pushed not only the government, but also healthcare providers to take really what we've seen as the most significant steps they've ever taken toward unleashing the power of telehealth services. So embracing change in the face of the pandemic, is something that a lot of our clients are seeing. Even healthcare providers who previously may have been reticent to use this type of technology with their patients are really moving in the right direction to do.
Another significant change pertains to the healthcare providers who can bill for the provision of telehealth services. Gina, can you tell us how this has changed?
Yes, the 1135 waiver for the duration of the COVID emergency has lifted the pre-COVID requirements pertaining to the state licensure requirements for telehealth providers. So prior to the public health emergency, telehealth services could only be provided by certain eligible providers licensed in the state where they are providing services, which would be the originating site where the patient is located. This requirement has been lifted, provided the healthcare provider has an equivalent license in another state. The waiver, however, doesn't waive state law requirements, so it is important to consider what is required at the state level, though, as I mentioned earlier, many states are providing increased licensure flexibility for telehealth services as well. And then in terms of what type of healthcare providers can deliver care, prior to the end of April, telehealth services could only be provided by certain eligible providers such as physicians, clinical psychologists, clinical social workers, registered dietitians, opioid treatment programs, and other mid-level providers. That requirement, arguably designed to keep telehealth narrowly constrained and to keep some guardrails in place related to quality of care, had not changed. But as of April 30th, when CMS updated its blanket waivers, CMS waived restrictions related to eligible practitioners. So now any healthcare provider who could otherwise bill Medicare for professional services can furnish and bill for the delivery of those services through telehealth. So that would include now physical therapists, occupational therapists, speech language pathologists, and others.
Leah, what about the technology that can be used to deliver telehealth services? Have those requirements changed due to the COVID-19 emergency?
Yes, Lindsey, they've changed significantly. So prior to the COVID-19 emergency, a telehealth provider was required to use a HIPAA-compliant interactive audio-video telecommunications system in order to receive Medicare reimbursement. Under CARES Act authority, CMS has waived the requirement that providers use interactive telecommunication systems to furnish telehealth services for certain services that would normally have required video technology. The waiver also allows the use of audio-only equipment to furnish services described by audio-only telephone evaluation and management services and behavioral health counseling and educational services. A bit later, I'll discuss the new reimbursement for these audio-only codes. So if you look at the Medicare telehealth list now on CMS's website, it will indicate in a column which CPT codes can be performed using audio-only technology. So it's not all the codes, it's only certain codes. For services on the Medicare telehealth list that must still be furnished using audio-video equipment permitting the two-way communication, previously providers had to use HIPAA-compliant systems, and they were not permitted to use devices devices, personal devices, such as iPhones and iPads. So that restriction has been waived, and now telehealth services can be provided using everyday communication technologies such as iPhones and iPads. The Office of Civil Rights, which is the division of HHS that enforces HIPAA, had announced on March 17th that it would not seek enforcement penalties for HIPAA violations by healthcare providers serving patients during the emergency in good faith who communicate using a non-public facing communication technology such as FaceTime, Facebook Messenger, Google Hangouts, etc. Even though those technologies may not fully be HIPAA compliant. But it did warn folks that they should not be using, it's not appropriate to use public-facing applications such as Facebook Live and TikTok. That's how it's changed.
So, Leah, you mentioned that the CARES Act and the interim final rules have provided further flexibility. Let's start with the CARES Act. What did the CARES Act address with respect to telehealth services?
Yeah, so the CARES Act, which was passed on March 25th, contained very targeted provisions that address telehealth expansion. As an example, the Act allows FQHCs and rural health centers to serve as distance sites for telehealth services where they aren't allowed under normal reimbursement rules. It allows qualified providers to use telehealth for hospice face-to-face certifications. It allows telehealth to be used for evaluations of dialysis patients. The Act also provides funding to multiple agencies to support telehealth expansion, including to the VA, to the FCC, and to the Indian Health Service. But to me, the most notable provision in the CARES Act is Section 3703, which grants the Secretary of HHS sweeping waiver authority to expand the use of telehealth for Medicare beneficiaries during the emergency. So basically, any of the statutory requirements related to Medicare reimbursement can be waived by the Secretary under the CARES Act.
Tell us about the interim final rules. When were they issued and when were they effective?
So the first interim final rule was issued a few days after the passage of the CARES Act on March 30th. That was the pre-publication copy. Working under the Secretary's waiver authority, which was expanded under the CARES Act, CMS expanded Medicare coverage of telehealth and other technology-based services in order to provide even more flexibility in combating the COVID-19 pandemic. It's really quite fascinating. This interim final rule focuses almost exclusively on one theme, which is providing care remotely through expanding the availability of services provided via telehealth, increasing reimbursement for those services, permitting flexibility with the modalities used to provide that care, which we already discussed, as well as other changes related to the remote provision of care. Those changes were retroactive to March 1st. The second interim final rule was issued on April 30th, and this was in response to CMS reviewing comments related to the first interim final rule. So the second interim final rule includes additional regulatory waivers and rule changes that provide even more flexibility to healthcare providers in furnishing services. It includes telehealth flexibilities, but is actually broader in terms of its scope. Many of the provisions in that interim final rule are also retroactive to March 1st, although not all of them.
Can you tell us about the substance of the interim final rules?
Sure. So there are so many interesting provisions in both interim final rules, and we have a limited amount of time to discuss. So I'll just go over just a few of the key provisions. Note that these changes in these interim final rules are only applicable during the public health emergency. So in the first rule, CMS had revised the place of service code and payment rate for telehealth services. Under the rule, providers were instructed to report the place of service code that they would have reported had the service been furnished in person. So rather than report POS 02 for telehealth, they're now supposed to report a telehealth modifier 95. The payment will be made at the non-facility rate for those services, which is higher than the facility rate. In the second interim final rule, CMS added that hospitals can bill the telehealth technical fee for services provided to a registered hospital outpatient when the patient is at home and the telehealth services are provided to the patient by a hospital-based practitioner. They're raising the telehealth reimbursement even more for hospital outpatient departments. In In the first interim final rule, CMS added around 80 additional codes to the list of eligible services on the Medicare telehealth code list, including ED visits, observation services, critical care services, and ESRD services, etc. The services can be provided either to a new or an established patient. In the second interim final rule, CMS waived the audio video requirement for certain telehealth E&M codes on that list. In the first final rule, CMS provided reimbursement for telephone-only consults that were not historically eligible for payment, even though those CPT codes always existed. CMS also clarified that those codes can be used for new and established patients. In the second interim final rule, CMS specifically added those audio-only codes to the Medicare telehealth list and increased reimbursement for those codes to match payments for office and outpatient visits. So again, increasing reimbursement, increasing the availability of services that can be provided remotely. Another interesting change in the first interim final rule is that teaching physician billing requirements regarding physical presence during key portions of the service can be met through direct supervision via interactive telecommunications technology. So this includes services provided under the primary care exception, which allows teaching physicians in certain primary care clinics to bill for the services of residents, and it's a commonly used exception. In the second interim final rule, CMS clarified not only can the teaching physician direct the care via telecommunications technology, but can also review the services provided by the resident via the same way. The second interim final rule also added additional CPT codes that can be provided under the primary care exception, including telephone E&M codes and transitional care management codes, as well as others. The first interim final rule modifies the definition of direct supervision to include virtual presence through interactive telecommunications technology when the use of technology may reduce exposure risks for the beneficiary or the healthcare provider. This new policy applies to physician services, diagnostic services furnished directly or under an arrangement in the hospital or in a hospital outpatient department, and also applies to pulmonary rehab, cardiac rehab, and intensive cardiac rehab. So the current definition under normal circumstances of direct supervision means that the physician must be physically present in the office suite and immediately available to furnish assistance. CMS did state that furnishing services in the absence of a physician's physical presence might not be appropriate in all circumstances, and so CMS is leaving those determinations to the physicians as to what services are appropriately provided with physician supervision via digital technology. And I'll just mention one more, which was CMS had previously updated policies related to payment for remote physiologic monitoring services, or RPM, under the physician fee schedule that included permitting RPM to be used with new patients with beneficiary consent to be obtained at the time the services are furnished and to be provided by auxiliary personnel and under general supervision. The second interim final rule allows RPM to be reported to Medicare for periods of time that are fewer than 16 days out of 30 days, but no less than 2 days, as long as the other requirements for billing RPM are met and the patient has suspected or confirmed diagnosis of COVID-19. So that's just a few of the many provisions and expanded availability of telehealth services and reimbursement that are available under those two interim final rules.
Gina, the U.S. Health and Human Services has expanded flexibility for opioid treatment providers as well. Can you describe those changes?
Yes, in light of the public health emergency, HHS in the first interim final rule revised federal regulations related to treatment furnished by opioid treatment centers to allow the therapy and the counseling portions of the weekly bundle of services that opioid treatment centers provide to be furnished using audio-only telephone calls. And this would be allowed rather than requiring two-way interactive audio-video communication technology if the beneficiary did not have access to that two-way communications technology. In the May 8th final rule, HHS further expanded that flexibility by allowing assessments, which are services that had only just been finalized as an add-on code in the 2020 physician fee schedule, also to be furnished using audio-only telephone calls rather than requiring two-way interactive audio-video technology. And again, provided all the other applicable requirements are met. So not only the therapy and counseling portions, but also the periodic periodic assessments that opioid treatment centers provide for their patients can be provided using audio-only technology. And there's some language in the interim final rule where HHS indicates it believes this change is necessary to ensure that beneficiaries with opioid use disorders are able to continue to receive those important services during the public health emergency. But HHS also cautions that opioid treatment facilities should use clinical judgment to determine whether they can adequately perform the periodic assessment over audio-only phone calls. And if not, they should use two-way interactive audio-video communication technology or in person as appropriate. So important changes there for opioid treatment services. And I'll just summarize to say that while we've tried to comprehensively outline the evolution of telehealth over the past 8 to 10 weeks, which really has seen a revolution in this area as compared to, the years leading up to the public health emergency, we certainly haven't touched on every change. And we encourage healthcare providers to seek guidance if you have questions about the scope or the way services need to be delivered and what is currently permissible under Medicare regulations. As far as what the future holds, this is a time of rapid change for healthcare providers and patients alike, as well as for telehealth solutions providers, of which there are many out there developing the tools that can be used by healthcare providers. And with each month that has passed since the declaration of the national emergency, we have seen a significant expansion of services eligible for telehealth, including the providers who can provide those services, the settings permissible for the receipt of telehealth services, most notably the patient's home for any diagnosis. And, we have seen that the federal government clearly through this expansion has recognized the utility of telehealth during this difficult time when people are staying home. What remains to be seen is what, if anything, will stick. Many of us watching the landscape closely and consulting with healthcare providers to get a sense of how this is all rolling out believe it will be difficult for HHS to unwind all of this flexibility. But others also have expressed concern that some of the additional flexibility, while enhancing convenience of the provider and of the patient, may not be in the best interest long-term for quality of care. And I think also what we're hearing from our healthcare clients is there is still reticence within the healthcare provider community to fully embrace telehealth, given the significant change and the fact that a lot of healthcare providers like to see their patients. They like to be in touch with their patients. So there's a real shift in the way healthcare is delivered that may still take some healthcare providers time to adjust to. We will continue to monitor the landscape and to report on it via podcasts and client alerts, and we're certainly available to provide guidance as needed.
Thanks, Leah and Gina, for joining this podcast. If any of our listeners have questions or comments, feel free to let us know. As for the other COVID-19 related information, please visit our COVID-19 Resource Center on our website and subscribe.
Thanks again for listening to Triage, rapid legal lessons for busy healthcare professionals. New episodes are available for download through iTunes, Google Play, and other podcast applications. By subscribing to Triage, you will receive timely notifications of each new episode. Also, if you have any topics that you would like to hear discussed on Triage, please don't hesitate to email triagesupport@klgates.com. We would love to hear from you.